Welcome to RWJBarnabas Health's Health Talk Show. I am Dr. Douglas Oshinsky of RWJBarnabas Health Medical Group. Alzheimer's disease is the most common form of dementia caused by the buildup of two substances in the brain called amyloid and tau that clump up and form tiny structures called plaques and tangles. These conditions make it harder for the brain to work properly. An innovative new class of therapeutics has shown benefit in slowing the progression of Alzheimer's disease by as much as 25% when treated at early onset. On today's show, we will learn more about Leqembi, a drug that slows down the progression of dementia resulting from Alzheimer's disease. We are pleased to welcome Dr. William Hu, Associate Professor and Chief of Cognitive Neurology and Alzheimer's Disease Clinic, Rutgers Robert Wood Johnson Medical School and Robert Wood Johnson University Hospital. Director, Center for Healthy Aging Research, Rutgers Institute for Health, Healthcare Policy, and Aging Research. Welcome to the show. Thank you, Dr. Hu, for being here. Can you tell us a little bit about your background and what got you interested in the Alzheimer's disease?
Sure. Thank you for having me today. My name is William Hu. I'm a neurologist, and specifically, I'm a cognitive neurologist. So I specialize in evaluating and treating people with memory disorders such as Alzheimer's disease. I really became interested in Alzheimer's disease during the decade of the brain back in the 90s, where there was a lot unknown about what was causing Alzheimer's disease, how do we better diagnose Alzheimer's disease, and how do we treat Alzheimer's disease. Over the past 20 years, I've had the fortune of being able to contribute to some of the scientific advances as well as the treatments, and we're really happy to be where we are today, that just before 2025, we've had our first few drugs approved for Alzheimer's disease since 2003, when I was still a medical student.
Thank you. Now, tell us what the definition of Alzheimer's disease is and how we diagnose it, and we'll go from there.
That's a great question. When people think of Alzheimer's disease, people often say dementia next. Well, the two terms are related, but they are not the same. Alzheimer's disease is the most common cause of dementia in North America and in Europe, but we don't know if that's the case elsewhere. When we use the term Alzheimer's disease, what we really mean is that somebody has cognitive impairment, dementia or not quite yet dementia, due to two changes in the brain. And these two changes are the neuritic plaques and the neurofibrillary tangles, which we abbreviate as plaques and tangles. And this was actually exactly how Dr. Alois Alzheimer described it back in 1906, which was the combination of plaques, tangles, and cognitive decline. How we used to diagnose Alzheimer's disease was we would have a clinical visit, carry out some pencil and paper testing, and perform a brain MRI to look to see whether there are areas of shrinkage that are in the pattern of Alzheimer's disease. This, unfortunately, was only so accurate. The accuracy in the best hands was about 70%. So if I were to see 9 patients a day, I would get 3 of them wrong, which was really not good. One of the greatest advances in the field, and which is also my particular area of research, is definitive biomarkers. Biomarkers are tests that reflect things that we cannot see clinically, such as the plaques and the tangles. So using these modern biomarkers, including those that we can access through the spinal fluid, as well as sometimes in complex and expensive PET scans, we can almost definitively determine whether somebody has these plaques and tangles in the brain without doing a real biopsy or wait till somebody has passed away.
So as a primary care doctor and doing annual wellness exams on people, we do mini cognitive testing on people. We do the clock, we do the, give them 3 words to remember and ask them to repeat them later on. We we ask them to do writings, we ask them to do certain things. And if I have someone who doesn't meet minimum criteria, that's when we start to look at whether they've got a form of dementia and or a form of Alzheimer's disease. Years ago, we would have to get an MRI in them, look for the the pattern in it to do it, and then we'd say, okay, the person's got Alzheimer's disease. So what are the causes of it, and what are the most common symptoms of it?
We still don't know what the causes are for Alzheimer's disease. We know a number of risk factors for the most common form, which is not familial. Things like high cholesterol, high blood pressure, diabetes are all risk factors for Alzheimer's disease. Other things such as midlife hearing loss and social isolation are also causes for Alzheimer's disease, or at least risk factors for Alzheimer's disease. In terms of how these lead to Alzheimer's disease changes in the brain and dementia, we still don't have a clear understanding, which is why there's still a lot of research going on in terms of if we were to improve someone's hearing or if we were to improve someone's isolation, can we reduce their future risk for Alzheimer's disease? These remain open-ended questions.
But again, what we're learning is that, again, it's the same thing like in heart disease, like in any type of diseases. We reduce the risk factors for long-term chronic diseases, and that hopefully reduces the risk of developing Alzheimer's disease. We reduce their cardiac disease. We reduce their pulmonary disease. We have them try to maintain a good weight, good blood pressure, good cholesterol. Avoid cigarette smoking if at all possible. If they are a smoker, making sure that they get onto some type of program, see their primary care to get off of the cigarettes, or going to the RWJ Smoke Enders program where they've got professionals that can help them get off of cigarettes. Making sure that if they are diabetic, that the diabetes comes under control, and if their primary care doctor and or endocrinologist can't help, get them over to RWJBarnabas Diabetes Education Center and get the educators involved in order to help reduce their sugar numbers, get their diabetes under control. Hearing, again, when people turn at the age of 50, we start to notice the hearing loss, and it really does isolate people. The person's constantly saying what, they're missing half of the things, they're becoming isolated, and that can, again, another risk factor. We have terrific audiologists who are part of RWJBarnabas Health who can help them, can go through a whole audiometry reading and may help them make a decision on the use of hearing aids so that they don't become lost souls. And the nice thing is these hearing aids are becoming much more modern. They have Bluetooth on them. You can hook them up to the TV, and most people hook them up to their cell phones so that they don't lose their cell phone conversations. So we do have things that help reduce the risk of it. However, we still don't know what the causes are. We hopefully, with the research, we will down the road be able to get the causes. The biggest problems have been treatment options. Up until recently, we've been using the medications we've been using for the last 20 years, and there hasn't been much of an innovation. And most of those medications, after about 6 months to a year, sort of start tapering off, and they don't work as well. I would start the person on an Aricept, and I'd go up to the maximum dose, and then when I noticed that they're starting to lose it, I'd have to add something to it. And even when I added the second medication, after a year or two, they'd start to plateau and maybe start to bottom down a little bit. So what are the treatment options at this point?
So when we talk about treatments, we usually break the discussion down to 3 parts. The first part is exactly what you just mentioned, what we call the symptomatic medicines. The medicines like donepezil and memantine, they only improve the symptoms, often transiently, and they don't last very long. And they don't really slow down the disease, even though there's a lot of talk in the community that they may slow down the disease. The reality is that they do not. They only improve the symptoms. They help you do a little better every day. But over time, people will still continue to decline at the same rates. The last group of treatments, a third option I want to talk about while we skip the second for now, is what we call the non-pharmacological therapies. Exercise, like you mentioned before, getting quality sleep, making sure you're socially engaged and cognitively active. Those are still important things, even with the newer medicines, which is the middle category we're very excited about and that we have rolled out very successfully. These are what's called the disease-modifying therapies. In a way, they're like the monoclonal antibodies that have been used in rheumatology and cancer for many years. So we finally have these antibodies that can target the harmful plaques in the brain and remove the plaques. And they are actually quite effective in removing the plaques. When we look at the clinical trials over the course of 18 months, all the plaques are almost completely removed by the end of the treatment program. And this is extraordinary because when you think about it, Alzheimer's disease changes in the brain begin to develop about 20 years before the symptoms begin. So we can effectively remove 20 years of toxic buildup over the course of 18 months. And again, that was just hard to imagine 10, 15 years ago, but here we are.
So tell us more about this. Well, of course, we first go back to, we want to help the person if we want to engage them. As I said, we get them the hearing aid. We get them into some type of cognitive therapy where, we make sure they go to the library, they read books, magazines, they go to, if they're a senior, they go to the senior center, they engage with other people at the senior center, they play bridge, they play pinochle. If they want, we get them more active, we get them a pickleball racket, we get them over to the pickleball court, or if they're not able to do that, bring them over to the bowling alley. Start doing things like that, engage them with them, so that they, hopefully by doing that cognitive stuff, that also helps improve their overall outlook on on Alzheimer's disease. But now again, the treatments, as you talk about these monoclonal type of medications, something very new, innovative, things that we hadn't had up until this point. So tell us about Leqembi. I can't even pronounce it. Leqembi, if you can pronounce it. What was that?
Leqembi.
Leqembi. Tell us about Leqembi. Tell us, is it available, how it works, and how do patients qualify for treatment? And how do you even give the treatment?
Yeah. So Leqembi is the second medicine of this class that showed a successful clinical trial outcome. And the successful outcome included not only the removal of plaques, like I talked about previously, but also slowing down of the cognitive decline by about 25%. And in Alzheimer's disease, there are 4 total changes. There are the plaques, there are the tangles, there are brain cell shrinkage, and then there's also bad inflammation. So coincidentally, when you're able to completely remove the plaques, it slows down the disease by 25%, 1 out of 4 of the changes. So a lot of the ongoing research is targeting the other changes. But in the meantime, we're administering this to as many people who qualify for the treatment as possible. This is a medicine that is infused through the vein. Leqembi is twice a month. So every other week, you would go into an infusion therapy center. They would put an IV in your arm. They would infuse the medicine in over the course of 45 minutes to an hour. And afterwards, you go about and resume your regular activities. Once the medicine is in, it works for some time in removing the plaques from the brain. Now, some people do have vulnerable blood vessels. And if you have vulnerable blood vessels, sometimes in the process of removing these plaques from the brain, people may sustain what we call microhemorrhages. A lot of times people talk about bleeding on the brain. That's a bit of an exaggeration. These are tiny, tiny bleeds that when we look at them on the MRI, we actually cannot see them on the regular MRI. Instead, we usually need a kind of a magnifying glass on the MRI to see them. And I often explain to patients, it's very similar to when you're picking a wound and you have a drop of blood or two. We don't call that hemorrhaging. We call that, a minor nuisance. But because these are concerning, we actually follow people fairly regularly, especially when they begin the therapy with MRI, so that we make sure that people do not develop these things. And so far, very few people have developed these concerning changes that require the cessation or pause of therapy.
So how does a patient qualify to receive this medication?
Well, because there is this theoretical risk, a serious outcome, a serious side effect, we need to make sure that people actually have Alzheimer's disease. This goes back to what we were talking about before, that for a long time, Alzheimer's disease was made synonymous with dementia when it shouldn't have been. So we need to make sure they have plaques and tangles in the brain, and this can be confirmed through a spinal fluid test that is easily done in an outpatient setting in our clinic, or through the use of two PET scans. One is a plaque PET scan, one is a tangle PET scan to confirm that somebody has Alzheimer's disease. In the spinal fluid, we just do one test, we can measure plaques and tangles at the same time. But in the PET scan, we in theory require two separate PET sessions. In addition, people need to have mild symptoms because the main effect of the drug is removal of the plaques over time and slowing down disease in the future. If there's already been too much cognitive impairment, this improvement will not be significant enough, will not be noticeable. So we like to change the trajectory of decline as early as possible. This is very similar to heart disease and cancer, that you want to intervene as early as possible, which is again why it's important to have the annual wellness visit, because that allows us to pick up people as quickly as possible before someone forgets to pay their bills or before someone forgets to pay their taxes.
Okay, so as a primary care doctor myself, who's an internist, who has a large Medicare population, what do I do to get my patients to you? Is it at the medical school that it's done?
Well, I think there are a few steps that need to happen before that. So number one is that Alzheimer's disease is not the only cause for memory loss. And like you mentioned before, a structural brain imaging of some sort, including just a CT of the head, may be sufficient to make sure there's not being a big stroke or a large tumor that's gone undiagnosed. And then if that's not the case, then certainly we're happy to take referrals at the Robert Wood Johnson Medical School in collaboration with Robert Wood Johnson University Hospital. We're the only site within Barnabas that's doing the workup in the infusion. And we can get people in fairly quickly to get a spinal fluid test done. If the results confirm Alzheimer's disease, then we will start infusion either at Robert Wood Johnson University Hospital or at an infusion site close to the patient's homes. In the near future, we hope to expand this capacity to Cooperman-Barnabas Medical Center as well as Monmouth Medical Center. We're just getting ready at these sites.
So the good news is that we've got something there that seems to be available, seems to be worthwhile, and something to really be considering. So I'll send them to the neurologist to confirm that they've got the Alzheimer's disease. And hopefully, since they are an RWJBarnabas neurologist, if they really do confirm it, and if they go through the cognitive testing and then they show it's a moderate form of Alzheimer's and not a severe, that RWJBarnabas neurologist will refer them over to you, and thus we can get the treatment for the patient.
Absolutely. And then it's also important to mention that Medicare does cover this. There's a lot of concern out there about the coverage because the newspapers have said this is really expensive therapy. It is an expensive therapy, like many other therapies, but Medicare does cover it.
Which is very important for the patients because since most of them are on fixed incomes, they really need to know that. At the same time, if we can moderate their disease, that also improves their overall health and reduces their risk of needing to go to an assisted living facility and or nursing home down the road. Avoid them getting into an accident if they're still able to drive. Making sure that they don't get into an accident or something, walking in the street, getting lost outside, things like that.
Absolutely. And then these are the very reasons that Medicare pays for it because it saves costs down the road. Additional things that can represent cost saving is caregiver time from their children who have to take time off work to take them to the doctors. A lot of the functional independence can be preserved based on this medicine as well as the ones that are new and coming down the pipeline.
So a patient starts this medication. How long do they stay on this medication?
So for Leqembi, the people will stay on for about 18 months. We are actually conducting quite a bit of research on what happens after the 18 months. The only reason 18 months was there is because that was how it was done in a clinical trial. In some of the emerging studies, it seems that people continue to benefit after the 18 months, but perhaps not as much as an initial 18 months. So in the future, we'll probably be able to come up with another test to see after the completion of 18 months, will you or will you not continue to benefit from this drug? And only those who will continue to benefit will continue on the drug, whereas the others, then they may potentially go on to other new medications that are yet to come.
Now, you said you're involved in research. Are you doing research in Alzheimer's also, other than
Yes,
this? So
absolutely.
other types of research that you are involved in?
Yeah, so as I mentioned, that Alzheimer's has four components: the plaques, the tangles, the brain cell loss, and the bad inflammation. We spend a lot of time studying the bad inflammation that we're actually leading the country in determining what bad inflammation is. So we already have some tests that can help advance that clinical utility. And we also trying to determine which drugs, experimental or otherwise already approved by the FDA, may be beneficial to be tried in clinical trials in addition to something like Leqembi. So we don't want to pull people off Leqembi and start them onto the inflammatory drugs. We want to really do a combination therapy such that we can improve the overall outcome. In addition, something that is very new to all of us is the impact of COVID. We studied long COVID in people who are in the middle ages, but we're also finding that a significant number of people with Alzheimer's disease have coexisting long COVID. How do we treat them effectively for both Alzheimer's disease and long COVID? That's an active area investigation.
So it's really nice, the fact that you're doing all of these studies right here in the local community, and that I do not need to send them all over the country to get the correct treatment and the up-to-the-date, state-of-the-art treatments.
Absolutely. We've been awarded a number of large National Institutes of Health grants to be able to conduct these research at home. And we actually have one of the only centers focused on Alzheimer's disease in minority populations in the country. So these are some of the accolades that the community needs to be aware of and take advantage of.
Well, also because they are Alzheimer's patients, it's very difficult to get them, not to take them outside of the community. And having this within the community makes treatment so much easier, makes follow-up so much easier. And, it's very, very difficult if someone's got the Alzheimer's to bring them to New York, to bring them to Pennsylvania, to bring them to Philadelphia. Go into New York, try to find parking and get into a place, and then you're waiting 2 hours to be seen there. There's no way you're going to be able to do that with a patient who's got Alzheimer's. I can do it right here in my own home base.
You're absolutely correct. And what's more, we actually conduct quite a bit of telehealth visit for that very reason. That if we can save someone 2-hour drive and from Cape May to up here, if you drive a little fast, and then still conduct the high quality care we otherwise deliver. Why not? So we've been very supportive of telehealth in that regard.
Well, that's the whole philosophy of RWJBarnabas Health, is to give the outstanding state-of-the-art care to our patients in a local environment. They don't need to go elsewhere. We have the proper people here. We've got the terrific clinicians here. We've got the great nurses here. We've got the terrific aides here. We've got the personnel here. And in addition, we've got the medications, we've got the researchers, and we've got a leadership that understands this and makes this possible.
You're absolutely correct.
So as we're getting close to concluding this, can you leave us key messages on what our audience should think about Alzheimer's disease and the treatments available at RWJBarnabas Health?
I think what I want to say is that not all forms of cognitive impairment dementia are due to Alzheimer's disease. And you're going to need one of the more advanced tests available at Rutgers and RWJBarnabas to determine whether the cause of your memory issue is exactly Alzheimer's disease. If it is, in addition to the older drugs as well as the non-pharmacological interventions, there are new drugs available, including Leqembi, that can effectively remove the plaques from the brain and slow down the disease by 25%. This is really one of the biggest advances in Alzheimer's disease over the past 30 years, if not 50 years. And we want people to take advantage of this.
So what we learn is that, one, get over to your primary care doctor, get your proper follow-up, make sure you reduce your risk factors for all diseases, cardiac disease, pulmonary disease, diabetes, because that may help reduce the risk of Alzheimer's disease. Get the evaluation by your primary care for Alzheimer's disease, doing the cognitive studies. If there's any concern, get them over to the RWJBarnabas neurologist, who can do further testing, such as either the PET scan, the MRI, in order to actually characterize whether it is Alzheimer's disease or whether it's any other form of dementia, whether it's due to atherosclerosis, whether it's due to clots being thrown out, whether it's even due to things like vitamin deficiencies. And then once it is determined that it is an Alzheimer's disease, we have someone like you that we can send them to at University Hospital, Rutgers Medical School, who can then go further and treat something that we hadn't really been able to treat up until this point. Basically, we would keep the person at a home or admit them to a assisted living facility or a nursing home and have aides with them. We now have something that can actually combat the disease process itself, slow the process down, and actually reverse some of the disease itself, which is something that we can't say with the other drugs we had presently. And
then those are really highly important things. And what I also want to encourage everyone to do is participate in research. Without research, none of these advances would have been possible. It used to be that people would say it may help the next generation. Really, right now, it's helping this generation. That's the pace of research. So please participate in our research. And with some of the uncertainties in federal funding, we will also appreciate any other type of support from the community in how we can continue and expand the research so that we can stay a center of excellence.
Thank you, Dr. Hu, for what you've done. Thank you for what you are doing and continue to do. And thank you for taking care of our patients at RWJBarnabas Health.
Thank you for having me.
That concludes today's episode of Health Talk. Please remember that the opinions expressed here today by our medical experts are not a substitute for medical advice from your own physician. If you need a physician, please call 888-724-7123. For more information about RWJBarnabas Health's neurology service, visit us at www.rwjbh.org/neuro, Neuro.